I'm Dr. Fakir Raveri, and this is a brief presentation on inpatient management of type 2 diabetes. Of course, diabetes can lead to different complications. In the acute care setting, we are interested in preventing infections, preventing hypoglycemia and hyperglycemia, which can lead to complications, and of course, we want to prevent mortality. There are different things that can lead to hyperglycemia in hospitalized patients. Acute illness itself can cause physiologic stress, which will cause increased cortisol and epinephrine, which can cause hyperglycemia. This is regardless of whether the patient has diabetes or not. There can also be drug-induced hyperglycemia. For example, many patients in the hospital receive systemic corticosteroids, which can cause hyperglycemia. While corticosteroids are the most common cause of drug-induced hyperglycemia, there are many other drugs that can occasionally cause hyperglycemia. Now, it's not to say that anybody who's taking these drugs will have hyperglycemia, but these drugs can occasionally cause hyperglycemia in patients. Another issue in hospitalized patients is hypoglycemia. In fact, some patients can actually have spontaneous hypoglycemia, and that can be due to critical illness, it could be due to malnutrition, and it could be due to other causes like malignancy and autoimmune syndrome. There are also some drugs that can cause hypoglycemia occasionally. And of course, there's iatrogenic hypoglycemia. So for example, patients who are not allowed to eat because of their illness or because they have a procedure coming up, or patients who are vomiting, for example, they can have hypoglycemia, especially if they have diabetes. Now, both hypoglycemia and hyperglycemia in hospitalized patients are bad. In this picture, on the x-axis, you're looking at different serum blood glucose levels, and on the y-axis, you're looking at the mortality rate. These data are from an observational study that was done in 2008. Now, whether you look at the unadjusted graph or after multivariable adjustment on the right, you can see that there is a U-shaped curve, which means that the rate of the risk of mortality is high when the blood glucose is too low, and it's also high when the blood glucose is too high. So there's a U-shaped curve here. So we just need to find the sweet spot in the middle. We need to avoid the extremes on either end. And these are even worse in patients without diabetes. So you can see this solid line is showing you data from patients without diabetes, and the results are even worse. So patients with hyperglycemia, they're at higher risk of dying. That stresses the point that in hospitalized patients, it's extremely important to manage both hyperglycemia and hypoglycemia. We want to avoid both of these things. Another thing to consider in patients who are hospitalized is that we want to promote the shortest safe hospital stay and provide an effective transition out of the hospital that prevents acute complications and readmission. When I talk about hypoglycemia, I'm using American Diabetes Association definition, which is a glucose of less than 70. And further, there are 3 levels of hypoglycemia. American Diabetes Association has 10 recommendations for inpatient management of type 2 diabetes. Now, obviously, in the acute care setting, for the most part, patients will be in the hospital for just a few days, and we want to avoid prolonged hospitalization in most patients. Therefore, we do not target A1C in the acute care setting. However, it is recommended to perform a single A1C when patients are admitted, just so we can have an understanding of patients' baseline. But when it comes to goals of therapy, we're not going to target A1C. Instead, we're going to target blood glucose, which brings us to the next question. What should be the sweet spot that we're going to avoid hypoglycemia and hyperglycemia? So what should be the goal in the acute care setting, which is different than the goals that we have for outpatient management of diabetes? The NICE Sugar study was a landmark trial that was published in 2009 in New England Journal of Medicine. This was a multi-center randomized clinical trial. And they wanted to look at patients with diabetes who were admitted to the ICU to see if intensive glucose control, meaning a target blood glucose of 81 to 108, compared to a control group of conventional glucose control, meaning a target of 180, would make a difference on 90-day all-cause mortality. And what they found was that 90-day all-cause mortality was actually increased in the intensive glucose control compared to conventional glucose control, which initially made investigators think that it must be hypoglycemia. So if your targeting a more intense glucose control, those patients are more likely to have hypoglycemia and therefore more likely to die. However, they found that although hypoglycemia was significantly more common in patients assigned to intensive glucose control, the association of hypoglycemia with death was actually similar in both groups. So here you can see the results at day 90. More patients actually died in the intensive glucose control compared to the conventional control, which was statistically significant. After further post-hoc analysis, another report was published in 2012 from the same landmark trial. And they made a couple of conclusions. One was that in critically ill patients, intensive glucose control leads to moderate and severe hypoglycemia, both of which are associated with an increased risk of death. And although hypoglycemia was significantly more common among patients assigned to intensive versus conventional glucose control, the association of hypoglycemia with death was similar in the two groups. In fact, American Diabetes Association says that while hypoglycemia is associated with increased mortality, hypoglycemia may actually be a marker of underlying disease rather than the cause of increased mortality. And to make this point even more clear, when they did subgroup analysis in patients who did not receive insulin but they had hypoglycemia, mortality was also increased in those patients who did not receive any insulin. So it might not be the fact that insulin caused hypoglycemia which caused death. It could be that hypoglycemia itself was more common in patients who were more severely sick and therefore more likely to die. So here are the recommendations from ADA for inpatient management. So they say that insulin therapy should be initiated for treatment of persistent hyperglycemia starting at a threshold of greater than 180. Once insulin therapy is started, a target glucose range of 140 to 180 is recommended for the majority of critically ill and non-critically ill patients. And of course, they do say that more stringent goals such as 110 to 140 may be appropriate as long as this can be achieved without significant hypoglycemia. And this is a expert opinion. It's not based on any evidence. And they do say that clinical judgment combined with ongoing assessment of the patient's clinical status, including changes in the trajectory of glucose measures, illness severity, nutritional status, or concomitant medications that might affect glucose levels, should be incorporated into the day-to-day decisions regarding insulin dosing. So generally in the ICU, you want to target the glucose of 140 to 180, and by extrapolation outside of the ICU, we also target 140 to 180. Note that ADA does not say whether this is a fasting blood glucose or postprandial or random, which causes an issue, especially in non-critically ill patients outside of ICU. So here are some expert recommendations for hospitalized patients that were published in American Journal of Medicine. So these physicians actually say that for non-critically ill patients, subcutaneous insulin is recommended. And for critically ill patients in the ICU, IV infusion of insulin is recommended. And for avoidance of hypoglycemia, consideration should be given to reassessing the insulin regimen if blood glucose are less than 100. And they say, and here's their recommendation, they say the fasting plasma glucose target of 100 to 140 and a random plasma glucose of 100 to 180. So that 180 threshold, they're using it for a random blood glucose, not for fasting. And they're recommending the lower end to be 100 in order to avoid the risk of hypoglycemia. In the acute care setting, we primarily use insulin to manage hyperglycemia. Of course, we have rapid acting insulin, we have short acting insulin, we have intermediate acting, and of course we have long acting detamir, glargine, and of course degludec. One thing that's important in the acute care setting is that we want to mimic a natural physiologic response to glucose. So in the shaded area, you can see what the natural physiology is. So normally there is some level of insulin that's present at all times in order to avoid gluconeogenesis. if the patient has normal amounts of glucose, and then after each meal, the body releases insulin to control the glucose that's coming from the meal. So in patients who do not have that capability of normal physiologic insulin release, we want to mimic as close as possible that pattern. So we do have the basal insulin that we inject by using long-acting or intermediate, and then for those postprandial sugar picks, we use rapid-acting or short-acting. There was the RABBIT-2 landmark trial that was published in 2007, and they want to actually compare basal bolus insulin regimen, which is what I just described, and compare it to a sliding scale insulin to see if it makes a difference for glycemic control. And here's what they did. So for the basal bolus regimen, they first decided what's the total daily dose of insulin based on body weight, and then they would give half of that daily dose as a basal insulin glargine, and then the second half they would use rapid-acting insulin glulicin, and they would break it into 3 and give it with each meal. And for the sliding scale, they would actually measure the blood glucose, and depending on what the blood glucose is, they would give some units of regular insulin. And here's the table for it. So patients would be placed on either insulin sensitive protocol or usual protocol or insulin resistant protocol, and then throughout the day, the nurse would measure the patient's glucose, and depending on the value, they would know how many units of insulin to give them. And this is referred to as sliding scale insulin. And here's what they found. Well, first of all, this study was done before the nice sugar study was done. So they were actually targeting a blood glucose level of less than 140. And you can see that the solid circles are the actual basal bolus regimen, so that resulted in better glycemic control compared to the sliding scale. So the sliding scale didn't actually achieve the goal that they had set to around 140. So this showed that basal bolus was a better strategy in acutely ill patients in the hospital, and there was no difference as far as hypoglycemia between the two groups. This was followed by another study published in 2009 that wanted to compare basal bolus with the long-acting Dedemir and Aspart before meals to cheaper option of NPH and regular insulin twice daily. And again, the results of nice sugar trial was not available at the time they did the study, so they were targeting a blood glucose of less than 140. And here's the protocol, just like before. With basal bolus, you give half of it as Dedemir and the other half you split it with meals. And for the NPH, they actually said, okay, 2/3 of the total daily dose will be given in the morning and 1/3 in the evening. For each dose, 2/3 would be NPH and 1/3 would be regular insulin. And both groups could also receive sliding scale supplemental insulin if the dose that they received was not sufficient to get them to go. So here's what they found. They actually did not find a significant difference between the two regimens as far as glycemic targets, and there was no difference as far as hypoglycemia. So this means that combination of NPH and regular would be a reasonable alternative to the Dedemir and Aspart. And then in 2013, they did the Basel Plus trial that wanted to compare just a basal bolus regimen, as described before, to patient just receiving basal insulin plus sliding scale, compared to a third group that only received sliding scale. And what they found was that the basal bolus regimen and basal plus regimen did much better than the sliding scale insulin alone. So the conclusion was that the use of a basal plus regimen resulted in glycemic control similar to a standard basal bolus regimen in general medical and surgical patients with type 2 diabetes, and is an effective alternative. And of course, basal plus means just the basal insulin plus the sliding scale, as opposed to giving a basal and bolus doses before each meal. And lastly, a study was published in 2015 to see if there's a role for pre-mixed insulin in the hospital. So one group got the pre-mixed human insulin which included 30% regular insulin and 70% NPH given twice a day, and compared that to the usual basal bolus regimen with glargine once daily and glucosamine before meals. And what they found was that although there was no difference between the two groups for targeting blood glucose, there was actually more hypoglycemia with the pre-mixed insulin, which was statistically significant. So having all this evidence, here's what the American Diabetes Association recommends. So for the critical care setting in the ICU, they recommend continuous IV insulin infusion, which with IV insulin, it's usually regular insulin. So you hear IV insulin, you want to think regular insulin, whereas when it's subcutaneous, it could be almost any other type of insulin, including regular. And they say in the non-critical care setting, they recommend subcutaneous, rapid or short-acting insulin. They do say that pre-mixed insulin regimens are not routinely recommended for in-hospital use. And they do say that basal insulin or a basal plus bolus correction insulin is the preferred treatment in non-critically ill patients who are not eating anything. So this correction, they're basically saying give a basal plus a sliding scale for patients who are not eating. And then if the patients are eating, they say give a basal plus a prandial bolus and any sliding scale for any additional corrections that's needed. And here's the important thing: the use of sliding scale insulin alone in the hospitalized patients is strongly discouraged. Now, what about non-insulin therapies? So pretty much anybody who gets admitted to the hospital, all of the oral and anti-diabetic agents are discontinued and they're placed on insulin instead for various reasons. For example, DPP-4 inhibitors can cause edema. GLP-1 receptors can cause GI symptoms. So think about it, anybody who's very sick and gets into the hospital, they may already have nausea and vomiting, and we don't want to cause any further with GLP-1. And SGLT2s actually have FDA warnings for diabetic ketoacidosis and urosepsis and urinary tract infections. And metformin, although it's a little controversial, it can also lead to diabetic ketoacidosis, especially if patients are scheduled to get contrast dye with any imaging that they get in the hospital, which I will actually talk about metformin on a separate topic. This concludes this presentation.